We're so pleased to welcome you to our second webinar for 2025. We're excited to have another great panel for you this evening. In addition to our Avant team, we're very thrilled to have some experienced and knowledgeable experts from Medicare with us tonight. First, I'd like to introduce David Nott, who is the Director of Medicare Corporate Compliance. David's worked in the department for over 20 years in a variety of roles with a strong focus on Medicare. It's a pleasure to have David with us this evening. Welcome, David.
Thank you, Tracy.
Next, we have Dr. Narendranathan. Dr. Narendranathan is a senior medical advisor at the department and a practicing GP. Dr. Narendranathan has kindly allowed me to address him as Dr. Naren this evening, and we're so grateful to have him join our panel. Welcome, Dr. Naren.
Thank you, Tracy.
From Avant, we have Dr. Patrick Clancy joining us this evening. For those of you who've attended one of our webinars previously, you'll know that Dr. Clancy is a senior medical advisor who's also a general practitioner and a former member of a regulatory board in Queensland. Welcome, Dr. Clancy.
Good evening, Tracy and everyone.
And next we have Justin Lagoulon, who is a very experienced senior lawyer from Avant's Medicare team. Justin completed his Masters of Law in 2016 and now advises medical practitioners in relation to many types of matters, but most significantly, he's an expert in relation to Medicare issues. Welcome, Justin.
Thanks, Tracy. Good evening, everybody.
Before we begin, the information that we provide in this webinar is general in nature, and if you do need specific advice, please contact us. So let's kick things off with some data on the claims that our members face. Pat, can you explain some of this Medicare claims information for us?
Yes, Tracy. As we can see in the orange bit of the graph up there towards the top left, Medicare matters account for 5% of all claims and complaints that Avant assists doctors with. The request for assistance with Medicare matters it's across the range of compliance activities that the department undertakes, including letters sent to doctors advising them to review their Medicare billing, audits, and preparation for practitioner review program interviews with the department's medical advisors. And we also assist members where they've been referred on to the professional services review, and from time to time when an AHPRA regulatory complaint has been made as a result of concerns raised with their Medicare billing. On top of that, Avant's Medicare Legal Advisory Service frequently receives calls from doctors and practices seeking clarity in relation to how they're billing Medicare.
So, Pat, what do the Medicare issues that we receive primarily relate to?
The two main issues we see are where it's alleged doctors may have claimed Medicare items when there isn't compliance with the requirements for those particular items, or where doctors may be engaging in inappropriate practice. For the non-compliance allegations, that's where doctors have generally done consults or procedures, but what they have claimed with Medicare may be incorrect. So, for example, when the service provider doesn't fulfil all of the requirements stipulated in the item descriptor or explanatory notes. Then for the inappropriate practice allegations, this might be where a doctor's billing data may be an outlier compared to their peers in the same type of practice. Sometimes these allegations can be answered to the satisfaction of the department, but many times they can't. Our data does show that 52% of the time, money had to be paid back to Medicare by doctors after they'd received formal attention from the department.
That's great, Pat. Thank you. So now it's time for you all to get involved. We've got a poll question to the audience. Have you ever experienced a Medicare compliance activity? So you can only select one choice, but if you can put your vote through, that would be very interesting to see those results. So while we wait for the results, let's consider a case scenario. Pat, could you walk through the case scenario for us?
Sure, Tracy. A doctor turns up to work in their private consulting rooms on a Monday morning. They've been away on holidays for the last 2 weeks, so on their return, there's a stack of mail sitting in their pigeonhole waiting to be read. One of those letters is from the department regarding Medicare. It's a busy day and it only gets a cursory read by the doctor, then it goes back on the pile of correspondence. Several days later, the practice manager sees the letter sitting on top of the correspondence pile and reads it. It's asking the doctor to review their use of several specific item numbers and includes the MBS schedule's item descriptors needed to meet the requirements for claiming those particular items. The department has specified the doctor needs to respond to that letter.
Oh, that's a scenario I'm sure some of our audience members are familiar with. So let's keep that scenario in mind and we'll come back to it a little bit later. Um, I wonder if we've got the poll answers now. Wow, luckily, 77% of our audience members have never received a Medicare compliance activity. Well, David, are those responses that you would expect from the audience?
So Tracy, I wouldn't really expect a certain amount for a particular cohort. I think one of the questions people will have in mind, certainly that I've seen through the questions that were pre-submitted, is do you aim to do a compliance activity with every specialist or every GP or every practitioner out there? The answer is no. We are led by signals, and it really goes to what Patrick was saying earlier, that if we're coming to you, we probably genuinely have a concern, and that concern is reasonably often going to be substantiated, sometimes not. And of course, we take a proportionate approach to compliance.
I think it's a question everyone has been thinking of when they entered to come along to tonight's webinar. So, David, could you go through some of the Medicare compliance programs?
Absolutely. So as some of you may know, Medicare, the big program, is actually a program that includes all funding for public hospitals, it includes the MBS, it includes the PBS, Child Dental Benefits and Practice Incentive Program. The benefits integrity area within the Department of Health, Disability and Ageing is responsible primarily for compliance for the 4 programs that you see in front of you. So that's $48 billion worth of taxpayer expenditure, and obviously a big part of the really important public-private mix that delivers, I think, very high quality healthcare out there in Australia.
So one thing I know, and you may have just touched on it then, some of us find confusing, is what is actually the role of the Department of Health and Disability and Ageing against what is the role of Services Australia? Could you explain that?
Absolutely. So first of all, I'm going to say, if you call me Medicare, I'll look elsewhere. Medicare Australia was a department that existed until 2011. It joined the Department of Human Services and eventually became Services Australia, which is what you can see off to your right. The compliance function, which was in Services Australia for providers, actually moved over to our department in 2015. So we don't necessarily consider ourselves Medicare, although we consider ourselves very responsible for Medicare because we have the responsibility for the legislation, the policy, and doing provider compliance. Services Australia are the people who are processing your claims, they're setting you up as billers, they're setting other people up as billers for you, and dealing with all other types of non-compliance, which primarily is public. So if there's any patient fraud or anything of that nature.
Well, that's very helpful to understand, and I've learned something already. I know that the audience will be interested to hear about the department's compliance approach. Could you walk that through with us, David?
Absolutely. So if you've been to one of these webinars before where the department is presented, you've seen a pyramid. In fact, if you've been to a compliance presentation, you've probably seen a pyramid by other organisations. And the pyramid that's in front of you really presents what I was talking about earlier, the proportional approach to compliance, which takes into account the seriousness and the spread of potential non-compliance in terms of the way that we might react to it. So the very bottom of the pyramid, which I'll talk about first, is, I guess, what we might call inadvertent non-compliance generally. And this covers really prevention and education in terms of the types of interventions that we might undertake. These tend to be voluntary interventions. And so you might have received a letter saying, we have some concerns about this type of claiming a particular item. Can you please review a schedule of data? You have the option to respond to us. We certainly encourage you to do so. Or you might even have received a letter that says, we have some concerns generally about what seems like a growing trend in claiming that doesn't appear to be strictly correct. Could you have a look at your own claims? And if you have any concerns, of course, you can make corrections through a voluntary acknowledgement, which we'll talk about later. So that's the first level, and just for everyone's knowledge, this is where I want to spend all my time. As a Medicare compliance officer, I always want to do education. Education is the most important thing to me. Education is prevention, and better informed is more compliant. So we would love to see that there were no interventions going back to the earlier response to the poll, because there weren't any interventions needed because we had great education. So the second level.
We're very glad you're here with us doing that education tonight, David.
It's always a pleasure. And so the second level is enforcement. And at this level, we tend to talk about audits. So that really goes back to the example that Patrick gave earlier, where we'll send you a letter, and what differentiates this type of letter, an audit letter, from a different type of intervention is we will say, please respond. So audits do come along with powers. They are backed by legislation. We don't tend to have to use those powers, just to be quite clear. It is most commonly the case that if we go out to a practitioner and ask for information, we get the information that we're seeking. And obviously, anyone who's responding to any of those letters, you have the option of getting any and all help that you wish. We have no concerns about you accessing help from a lawyer, help from an organisation like Avant or anything like that. And I think Naren might talk to the next one.
I am going to talk about the practitioner review program. Practitioner review program usually covers about 50% of the issues practitioners write to papers and everything most of the time, even though usually less than 0.5% people are involved in this program in a year. And it is a program where the practitioner comes to our attention due to our data systems saying there are some provisions of the service which looks different to majority of the peers, but that it by itself is not an important issue. But if there is the whole profile of the person, the number of patients a person sees, how frequently they see, what type of tests that are initiated, what is the age group of the patient, and what type of scripts are given, that gives a composite picture of whether the whole thing matches up. If those matching doesn't happen, then we form a concern, could it be inappropriate practice? But inappropriate practice is not what we determine. We think whether there is a concern of inappropriate practice. So we usually go to the next step then and look at the data first by a senior medical advisor. Then if the senior medical advisor, after looking at the whole profile, is concerned there is still some ground to suspect there may be inappropriate practice, usually transfers the case to a medical advisor. They usually contact the medical practitioner or allied health practitioner or medical specialist, send them the data we have on their billing, and also write up a list of concerns and say where to look for that particular data. So it is a very relatively exhaustive letter explaining what we are concerned, and please look at these tables because it will give you some understanding of why we are concerned. Then usually talk to the practitioner in about 2 weeks' time, get their response to the concerns we have, and also explain why we are concerned, because there is no point in just getting a feedback, but also telling why this concern arose. And if the practitioner is satisfied by his explanation, then we will close the case. It happens in a small percentage of cases, because we usually don't try to bother practitioners with the practitioner review program. That is why the cases are generally selected for well-defined concerns. And after the interview, the practitioners are usually given a 6-month review period so that they can sort of digest the concern we have, talk to their peers, and work and understand what we are saying matches it. If they decide to then change their practice, that is good, but there is no requirement to change their practice because our concerns are based on statistics. The practitioner actually sees the patient. So we usually tell the practitioner, if you think what you are doing is appropriate, please continue to do so. This is not a threat to say, stop doing something. This is to say you are outlier, the internal concern, the explanation you have has not altered our mind about the concern. And if the concern persists, at the end of 6 months, we review the person's profile again of the, again, pathology, diagnostic imaging, X-rays, everything are looked at. And if the concern persists, we usually send to a senior medical advisor who looks at it and decide whether to take it further. And if we decide to take it further, he will usually write a list of concerns. And this time the practitioner is given an option of responding to it in writing. If the practitioner's response adequately addresses the concern, the case is closed again. If not, he is referred to the Director of Professional Service Review. I need to say one more thing about this process. There are sometimes some practitioners at the initial interview are referred directly to the senior medical advisor for review to see whether they need to be sent to Director of Professional Service Review. These are in a very minority of cases where the type of concern is so out of whack with normally what we see, and also that it would be generally we consider unacceptable to their peers. And now, Tracy.
Thank you, Dr. Naren. That was really helpful. And because this is such an important topic, we do plan to have another webinar in the future that focuses more on the PRP process. But Dr. Naren, while I've got you here, one of the issues which is always high on the list of questions we receive relates to what actually is inappropriate practice. Could you explain what is considered to be inappropriate practice for our audience?
I will start by saying inappropriate practice, only two people can decide. The practitioner themselves accept they have practiced inappropriately, or the Director of Professional Service Review and the committee he appoints that can decide someone has practiced inappropriately. As a Department of Health Compliance purpose, we only have concern whether someone's practice may be inappropriate, looking at all the parameters. So people should be aware that it is only two people, the concerned party or the Director of Professional Service Review, the committee he appoints, decides on it. Inappropriate practice is defined in the Health Insurance Act, 1973, Section 82, which says a practitioner engages in inappropriate practice if the practitioner's conduct in connection with initiating, rendering services, which will be found by a committee of peers to conclude, would be unacceptable to the general body of the peers. So it is the committee of peers, in addition to the practitioner, who decides it is inappropriate practice. And it is in the conduct in the initiating and rendering of services or prescribing under the PBS. And another inappropriate practices, which we will come to later, but just as a quick thing, when someone has breached 80-20 or 30-20 rules, then they are automatically deemed to have practiced inappropriately by the law. So usually the medical advisors in those instances contact the practitioner to get a response, but as a department, we are unable to resolve the concern because the law requires the practitioner be referred to the Director of Professional Service Review. He or his committee can conclude whether it is inappropriate or appropriate after discussing with the practitioner.
Yeah.
And also another part of the inappropriate practice, which is important to know, it is not only the practitioner who renders and initiates the service, but a person who negligently or recklessly or knowingly cause someone to practice inappropriately is also can be found to have practiced inappropriately. Not only that, if it is a person, if it is a body corporate, an officer of the body corporate can also be found to have induced inappropriate practice. So it is practitioner, someone else who induces them to practice inappropriately, or a officer of a body corporate. So this is in big body corporates which run practices, they can be charged for inappropriate practice as well. And Dr. David Nott usually looks after that part of the business.
Thank you, Dr. Naren. And we might go to David. I think if we go back to the pyramid, the last part of the pyramid we're yet to consider is the very top, which involves fraud investigations. David, are you able to provide some clarification on that issue?
Yeah, so very briefly, as you see, the pyramid to an extent reflects intent. It's not strict, so it's not a one-to-one, just to be clear to people. But when you get to prosecution and fraud, there is going to be intent. If we are pursuing someone down a criminal path, which obviously goes to court, goes through the Director of Public Prosecutions, and there's an evidence brief that has to be prepared and all the things that you might expect, that person has essentially defrauded Medicare, most likely, and court outcomes reflect that. So if you're at that point in the pyramid, you probably expected us to be quite honest. It's not actually by any means just practitioners who engage in fraud. It does happen. It happens in the PBS, it happens in the MBS, it happens pretty much by all parties, it happens with receptionists, and pretty much anyone who can get their hands on money. And that's just an unfortunate reality of payment systems, that there are some people who commit fraud.
Thanks, David. So there are several ways that doctors and others can come to the department's attention in relation to compliance activities. One of those is through incorrect claiming. Justin, would you please provide us with some information on Avant's experience in relation to incorrect claiming?
Yeah, thanks, Tracy. I think there's been some really valuable information there by way of background from the department, and thank you to David and Naren on that information. As has already been outlined, people may be detected if they're an outlier in the relation to their use of the MBS. So, look, Medicare is a complex and a complex system, and like all healthcare systems, require good governance. And we've already talked too about that unacceptability test. So it's not a reasonableness test; it's an unacceptability test. So generally, if you're engaging in good medical practice and good governance, then our experience is similar to the data we had in our poll before. Members will rarely be involved in this, but what are the things that we find are looked at carefully? Is there a clinical necessity for the use of the item number? Would this service be considered clinically relevant to your peers? Will patients benefit from the use? And you've provided the appropriate level of clinical input to meet all the rules and the item number descriptors. And an important one too that's not on this slide too, I would say, is that like all medical legal matters, that you have good medical record keeping, so adequate and contemporaneous records that can support your use of the item if you later come under an audit process.
Thanks, Justin. We might turn back to the department. Dr. Naren, are you able to give the department's perspective in relation to incorrect claiming?
The predominant important area is when there are timed consultations. The time requirement is an essential part of the item. So it is not the volume of medical input I gave, it is the time that is important for time consultation. All other consultation, like specialist consultation, there is no time requirement for majority of the item. So that is one of the commonest issue we identify. And sometimes not fulfilling the item requirements, basic item requirements. You might see someone who would have done 20 chronic disease management item in a day, and then you look at their profile, you think, oh, he has in addition so many other things. You would have thought there is probably some incorrect claiming happened here. Otherwise, that volume of service is possibly not possible to be done. And also there are other incorrect claiming, which is less prevalent, but just for noting purposes. Sometimes people bill in someone else's name or bill on a different date so that they would not breach 80-20 or 30-20. That type of incorrect claiming also takes place. And sometimes people from overseas come without medical insurance, and it is billed in one of the sons or daughters or grandson's name. But these maybe look okay at the time, but later on when that particular person applies for insurance, they have to declare they had asthma, which they didn't have. So it also puts the patient at risk.
And your documentation is going to be critical to responding to any of these issues, isn't it? Absolutely.
And also, a lot of time when I have discussion with the Director of Professional Service Review, he would say, there was a note, BP 120/80, billed for level C consultation. How can somebody justify level C? They might have something that has happened, but there is no evidence of anything happening other than blood pressure check or script written, and that is the only evidence there, and the indication may also not be there. So how can someone justify that? So it is adequate contemporaneous notes, as Justin said. Good notes are good defense, bad notes are bad defense, no notes, no defense.
That's our favourite saying at Avant, Dr. Naren. Thank you. Let's move on to another area which is relevant, and that is incorrect prescribing. Pat, are you able to share some information regarding incorrect prescribing?
Yeah, thanks, Tracy. It's actually somewhat similar concept to Medicare item numbers. When we see letters from the department that has a doctor's Medicare billing data, there's often also data relating to PBS prescriptions in that same letter. It falls into the remit of the department's compliance activities. PBS scripts need to be done according to the requirements stipulated by the department, very similar to how Medicare item numbers need to be billed in a compliant way. To support compliance, we do encourage prescribers to be aware of a few things. It sounds quite obvious, but prescribers need to be constantly aware of the indications for everything they prescribe. Most will be well across the requirements for PBS authority scripts, but there are many other medications as well that have what's called a restricted benefit. With both authority scripts or where there's a PBS stipulated restricted benefit, you simply can't prescribe and tick that little PBS box on your script unless the indication exists as per the wording in the PBS. When prescribing under the PBS, it's also important to ensure your scripts are actually clinically necessary. Same as when you're doing a Medicare item, it's got to be a clinically necessary service that you're providing. And your clinical records need to clearly justify the reason for each prescription. Unfortunately, we do see plenty of clinical records where it's not clear why particular scripts were provided.
I think clinically necessary is there's some very important words there. Thank you, Pat. Dr. Naren, do you have anything to add in relation to incorrect prescribing?
Yes, one of the main issues we see when patients are prescribed in excess of what is allowed. And when you look at a patient who has been given an antidepressant script and you say on average there would be 12 scripts or 13 scripts per year, there is 15 scripts, and this is less worrying from an antidepressant type of thing, but antipsychotic, opiates, and sedative hypnotics, that type of medication. Either the patient is using in excess and there is a health issue with that usage, or whether the patient is selling in the open market and we are facilitating addiction. So that is another issue. As Patrick said, the most important thing is the medications are classified into 3 groups: general, restricted, and authority. The general, you can give it for generally any condition which your peers would agree. Restricted is restricted to a particular condition. If the condition doesn't exist and you think the patient would benefit, you are going to prescribe outside the PBS, and please tick the box indicating that it is not for PBS. And it is very easy to do. But sometimes practitioners are concerned about patient welfare and they tick the PBS box. This may land them in some time trouble.
Thanks, Dr. Naren. David, can we go on to the next area of non-compliance, which is business arrangements?
Absolutely. And I saw a question in the chat. Can you give some examples? This is both a business arrangement and a PBS prescribing concern. I'm just going to say semaglutide. Some of you know it as Ozempic, some of you know it as Wegovy. That's a live, very important issue to us, and one that we've been, I guess, looking at very closely along with the TGA and others. So business arrangements, corporations, companies. We have no problems with companies being involved in healthcare. They have to be, they need to be. It's very important. Some businesses structure their arrangements to maximize profits. Some businesses, I'm speaking in the very broad when I talk about businesses. If people weren't aware, my immediate past role in terms of the double dipping question that came through earlier was the Director of Public Hospital Compliance. So we understand arrangements are sometimes put in place that either seek to maximize profit or put you potentially in a situation where you're not entirely sure that you're going to be in good, safe hands, if I put it that way. Perhaps when you engage with a business, they say, we need to do all your billing for you, and you don't get to look at it. Perhaps when you engage with a hospital, you get the same information, and they say, we just do this in this state, in this hospital, in this company. These are concerning things, and you have every right to say, well, I'm not comfortable to work under that kind of arrangement. So there's some examples on the page that you can see before you. Prohibited practices, i.e. lease arrangements that include incentives for referrals. The other term that you might use is kickback type arrangements. Corporate structures that pressure you to meet targets. A certain number of services you must provide per week, regardless of the clinical need for patients. Clinical need drives everything when it comes to Medicare. And the patient decides models is pretty much the same thing. So lots of scripts. To be honest, during COVID, we saw lots of requests, and in some cases, more requests than I think any single practitioner could manage to do in one day, with some of the numbers that I was seeing coming across my desk. So be wary, get advice, probably from your insurer in the first instance, but certainly my advice in terms of business arrangements and companies is be careful what you engage with. Guard your provider number and your claims carefully. You have every right to look at them. There are ways through the health professional online services system. So keep an eye on it and think carefully about the businesses you engage with. Thanks.
Such an important message there, David. And I'll ask you another question following on from that. If a doctor finds themselves in a situation where they are concerned that they may have billed an item number in a way which they later realise does not meet the requirements of the MBS, what can they do then?
So if you do a web search, or we've got I think a slide here, yes, on voluntary acknowledgements of incorrect payments. So if you do a search for some of those terms, it will come up. You can always self-correct. We encourage, just as I'm sure Avant does and any other company, do your self-audits, understand what's going on. If you find issues, prospectively correct them ahead of time. It's the best thing to do. It saves that scary letter that you get in and you go, oh, the department's writing to me, what is this about? And that's the process if you follow the process through the website there. So the QR code, and as I said, it's can be found on an easy web search. So some of our letters we will ask you if you wish to make a voluntary acknowledgement. Some we may not. So the audit letters, we may not necessarily ask that. Again, you don't have to wait for us to contact you is probably the key message there.
Thanks, David. So let's turn to Avant. And Justin, when a doctor approaches you in this situation, what advice do you give in relation to voluntary acknowledgements?
Yeah, thanks, Tracy. And I'd agree with everything David's just said. The voluntary acknowledgement of incorrect payments system, we think, is a logical and good system. Have there any complex system, incorrect billing can occur. And so it's only natural you've got a process there. And our advanced experience and our advice to members when we're assisting them in legal matters is that if you've identified incorrect billing, then the right thing to do is to use that system to pay it back.
Thanks, Justin. I might go back to you, David. Can you describe some of the compliance issues that the department is currently focusing on?
Absolutely. So I guess from a personal perspective, so I won't read through this list. From a personal perspective, I've said this in many conferences and webinars recently. Telehealth has been a great thing for all of us. It's really facilitating patient access. It's doing great things for all of us. It's really a risk area, if we're honest, as well. A risk area for practitioners to fall into habits that comprise poor clinical practice. In some cases, we're hearing about patients who are simply talking to an AI rather than talking to any practitioner at all. And that AI may be facilitating prescribing or requesting or even some part of a service. So a range of things in that area. The corporate influence, I should mention the Phillip review in 2023, Medicare compliance. It had a fairly heavy influence on, focus on corporate influence. We have been, as it says there, we've been increasing our data analytics. We've been doing more data matching. I'm going to say overseas claiming. I say that knowing that I'm probably going to get a flood of chat questions immediately when I say that. But it is a current thing that we're working on, and we are finding quite a bit of non-compliance there, or potential non-compliance. So people are getting letters about that. So this is our compliance priorities for this year, and it covers some of those areas. Attendance items and management plans. I saw there was a bunch of questions about item 132 in particular. I think we're going to cover that later on. Full disclosure, I helped design that item, and it does have a particular purpose, which I think is sometimes not necessarily understood. Item 133 as well for consultant physicians. Bulk billing and extra charges. This is really important for all of us. So the government's just committed $7.9 billion into, I guess, incentivising more bulk billing within the system. We need to make sure that there are not extra charges being levied to patients, because that's not bulk billing. That's charging a copay. Claiming of high-cost PBS medicines and the other ones I won't go through in detail. You can see duplicate payments is there. So again, for the double dipping question that came up earlier, which the driver for us to be concerned about double dipping, as we call it, or duplicate payments, is not about private health insurance per se. There are reasons that a private practitioner can absolutely claim a service validly on public hospital grounds. But sometimes we do see that the MBS and public hospital payments through the National Health Reform Agreement are funding a single service. And fraud is always there. Criminal activity is always concerning. And we see a lot of it in particular in the PBS as well as MBS. Thanks.
Thanks, David. Just on that issue, are you able to add any more information on the priority regarding the MBS services while overseas?
Yeah, so, and I saw some questions that came in as well on this issue around when might I get a letter. You can always, I don't expect most people will, just to be clear, you can always familiarise yourself with the section of the Act that says services must be done domestically. So that's Section 10 of the Health Insurance Act. That's the general framework for Medicare, whether it's the PBS since 1953 or the MBS since 1983. It's a service for Australians within Australia, or obviously we do have reciprocal healthcare agreements and other reasons that you can get services. So it's not within the current policy framework, if I put it that way, to go overseas and provide a number of services to people who are located domestically within Australia. And that is what we are I guess, taking action on recently. A number of people received letters, and more probably will over time as we uncover more of that activity. And we're doing that through data matching. So we can see the travel records. We are making sure that we are checking carefully to ensure that people have travelled, and then writing out and asking those questions.
I think that's really important to know that there are all of those methods to check the data and gather the information. So everyone needs to be aware of the item numbers and the times and dates that they're billing. Thanks, David. Justin, are you able to talk to our experience at Avant?
Yeah, thanks, Tracy. I think David's covered it very well, and that slide covers those important issues that we've seen in this current campaign in looking into overseas claiming. Look, we see these campaigns come in various trends over the years. For specialists, we might see the compliance trend looking towards people co-billing procedural item numbers with consultation item numbers. When that consultation item number is a complete service. There's other things we've seen in trends like the use of nurse-assisted item numbers in chronic disease management. But yes, this is the latest, one of the latest campaigns we've seen, and I'd agree. It shows that interdepartmental cooperation across government that helps with Medicare compliance, and I think this is a good example of it.
Thanks, Justin. David, I might go back to you because one of the other questions we repeatedly receive relates to bulk billing, and specifically whether any other charges, say for bandages or other items, can be claimed if a doctor bulk bills the attendants. Are you able to provide some insight in relation to bulk billing?
Yes, and this is a nice, easy one in some ways that we can answer quite generally. You can charge for a vaccine which hasn't been funded through another program where you are bulk billing. Other than that, extra charges are not permitted. So we've seen various styles of this. We have seen membership fees. We have seen upfront pay to access type schemes. We understand why they exist because companies and practitioners out there are looking for a certain level of remuneration. But it's just really important to keep in mind the rule around bulk billing, which is 20A of the Health Insurance Act. Again, if you like reading legislation, which most people don't, the rule around bulk billing is no extra charges are levied to the patient other than for that vaccine.
Well, I'll go back. Thank you, David. I'll go back to Justin because he does love reading the legislation. Justin, can you provide a comment on bulk billing?
Oh, look, I think David's really covered it nicely there, and our experience and our advice to members is that it's a privilege to be able to have the assignment of the Medicare benefit come directly to you through the bulk billing system. That's a great privilege that's available to doctors. So therefore, we would agree that you could be very careful with compliance not to have those additional charges. And so I agree with David's summary there.
Justin, while you're here, I might ask you, so we've now heard about the department's compliance focus. Can you share with us the advice that you give to your members and the member doctors on how to ensure that they're meeting Medicare requirements and seeking to avoid compliance action being taken?
Yeah, look, I just think that we've covered some of these issues too, but just ensuring good governance. And many of the issues that will make you good in your compliance and Medicare will make you a good medical legal practitioner as well. So knowing the rules, knowing the MBS item numbers and descriptors, ensuring that will help you certainly know if you're doing compliance with your peers too, and auditing your use of the MBS, then you'll know whether or not your practice may be considered unacceptable or not. And maintain control over the use of your provider number. Liability falls with the provider number. So it's a very, with that great privilege to use, the Medicare system becomes a lot of responsibility too, to make sure that you know that your item number is being used appropriately. And again, we're harping on about it, but it's true. Good record keeping will, as far as Medicare compliance, and when we're assisting practitioners, other areas, medical legal areas, you might be able to rely on your usual practice, but to show that you've met that item number descriptor, then you need those adequate and contemporaneous records to show that you've met the MBS.
You absolutely do. One of the other important tips that are there, avoid professional isolation. Pat, can you explain what that means and how a doctor can avoid professional isolation?
Yeah, Tracy, the big thing's keeping in touch with your peers, and that's in relation to a few aspects, both talking about Medicare and PBS requirements and changes from time to time, but also just in general with your usual ways of being across developments and issues in your type of practice. It does need to be done with a degree of caution. Don't assume that just because a peer says they bill a certain way, that it's okay for you to bill that certain way. Sometimes if it seems too good to be true, or if nobody else knows about it, then probably it is too good to be true. Go to MBS online and read the item descriptor and notes yourself. Just be aware that you may not be getting the correct information from your peers, but it is a good starting point. Also be really alert to when someone in your practice, such as an owner or a manager, is pushing you to bill a certain way. We've had questions about this. Remember that ultimately you're the person who's responsible. You're the one that has to answer the department if there are later concerns regarding whether that billing was compliant. If there are item numbers that require several criteria to be met to be billed, sometimes it's useful to have a little checklist so that you can just go, yep, I did that, therefore I can bill that item number. And then it might be useful to also create your own list for item numbers you commonly use. So a classic example is GPs doing skin excisions. There's numerous skin excision item numbers depending on the size, location, histopathology. If you do a list like that, just make sure it's still got the info that you need to determine whether the item number is applicable. We do see people where they've done a summary and then the requirements for the item descriptor have been lost, and then they get a bit surprised when they go back and read the actual item descriptor again. And finally, there's lots of resources available to assist in all things Medicare. The department and Avant both have lots of online educational material now. You can review that, refer to it, and you can also contact our Medicare Legal Advisory Service at Avant if you've got specific questions.
Thanks, Pat. We might go back to the department, and Dr. Naren, one of the other points was to know the rules. Can you explain what doctors can do to know the rules?
The most important thing in the Medicare billing is the service should be clinically relevant. If the service fulfills the item descriptor, but it is not relevant, it is not billable. Because the other reason for it is, we talked about professional isolation, because we need to know the social norm for functioning society. In the same way, we need to know the peer norm for billing Medicare. What is an appropriate service in a particular clinical context? So the service should be clinically relevant and fulfill all the item descriptors, not part of the item descriptors, and there should be sufficient clinical input. I was talking about BP 12080 repeat script. It doesn't show sufficient clinical input in that situation. And also remember, unless otherwise specified, the MBS items are complete service. So if you are excising a lesion, the payment is for the excision, follow-up, removal of sutures, but the billing should be on the date of excision. So these are rules. And also, if you do, one of the other questions that came up was whether you can bulk bill a service and independently, privately bill another service. It is important to know that consultation item can be bulk billed or privately billed. But if you are doing a surgical item, you need to bill the whole set of item privately or as bulk bill. But if you are doing 2 or 3 different services, but they are non-surgical items, you can bulk bill one item and privately bill another item. That is allowed. And also, implementing good administrative control of your provider number is the most important thing. Medicare is the biggest honor system in Australia. It depends on people billing appropriately, and the payment is made the next day. There is no delay. That is why we come after post-payment compliance, because we don't want to interfere with the practitioner's income streams. So good administrative record keeping and having sufficient information is always important in that respect. And your provider number, I will tell it again, it's like a signature. If you give your signature on a blank check and somebody writes $2 million, you are still responsible.
That is wonderful advice, Dr. Naren. Your number is like your signature. I think if that's what we take away from tonight, that makes all of the time worthwhile. Going back to a similar point, the next tip was about maintaining control. I think Dr. Naren's covered it in his response, but Justin, can you provide some insights on maintaining control?
I think my fellow panelists have covered a lot of these issues very well, but it's as you've said, it's with that great power comes great responsibility, of course, and you should be maintaining. We would say at the end of the shift, check your billing. One of the main questions in a compliance situation at some of the high levels of compliance is, do you decide what your billing is? Are you looking over and checking it? And so have that as part of your daily practice, is that you're checking your billings at the end and making sure that you're comfortable with them. Another tip I would have, which we haven't raised yet, is, and maybe only a Medicare lawyer would say this, but have the MBS online as saved as a favorite. Refer to that. Know the only use a item number which you know, and you know the MBS criteria and the rules. So there's some extra tips.
Thanks, Justin. Dr. Naren, I think the most important advice, and you touched on it earlier, relates to good record keeping. Are you able to add some more insights on that issue?
The notes, as I said earlier, is the most important part in any issue that arises. The note should be clear for a particular patient. This is for the named patient, has a separate entry for each attendant. And if you are doing 2 or 3 services and billing for 2 or 3 items, it is important to have a separate section which says this is what happened under this section, so that someone looks at the notes, it can clearly identify. And this is important, especially when multiple surgical items are billed. Sometimes we ask for notes to see whether we could pay for this item, but if there is no evidence the item has been operated, the person has been operated for that particular service, it is like, how can we pay? And contain enough information. And also, the most important part is it should be clear, so that if it is my patient, if I drop dead tomorrow, someone should be able to continue the care of the patient.
Thank you, Dr. Naren. Justin, I might go back to you. Are you able to give some advice in relation to record keeping in the context of Medicare compliance?
Yeah, I think I'd agree with everything Dr. Naren said there, and that's when we're assisting practitioners under review, that is a key part of what is looked at. Would a fellow peer looking at those records be able to take over care of that patient? So that's a fairly good measure in my view, and just building on what Dr. Naren said.
Thanks, Justin. As our time for the hour is getting away, we might go back to the case scenario that we raised at the start of the discussion this evening. Pat, can you tell us what's going on for our doctor?
Yeah, our doctor finally gets around to completing the audit as requested. They realise they've claimed incorrectly, and so with support from the Medical Defence Organisation, they got on the front foot and contacted Medicare, made the voluntary acknowledgement of incorrect billings and repaid the amount to Medicare. They then went on to review their practice, put steps in place to maintain a tighter control over what item numbers were used. They've adjusted their documentation practices to ensure they record further details necessary for the item number, both at an administrative level, but also making sure their clinical notes are going to reflect the item numbers that they've claimed.
Thanks, Pat. So, as we're wrapping up the main part of our conversation this evening, could I ask for some key points from the panelists? I'd ask you first, David, if I could, for your key insight.
Yeah, so put very briefly, the healthcare landscape is changing and in many ways, in good ways. Do you use telehealth? Do you use AI? Be very careful about how you use those things. Be very careful about your engagement with other people who have access to your provider number. You can check your own billing. There is health professionals online service. Don't just accept this is how it must be done when people tell you that. If you want to sign up for a contract, that can be risky.
Thanks. Absolutely important advice. Dr. Naren, your key insight.
Your provider number is like your signature equivalent. If you entrust your signature or provider number to someone, you are responsible for what is in it.
Wonderful advice and very important. Pat, your insight, please.
Yeah, ensure your billing of every Medicare item number is for a service that meets the item descriptor and explanatory notes, and that your own clinical notes will support that if they are ever reviewed.
Wonderful and important advice. Justin, your last thoughts, please.
Yeah, I think we've talked about how you might, our experiences from Avant Law is that you might come to the attention of compliance if your numbers are an outlier. In other words, you're seeing large numbers of patients in particular services. And I think it's a bit of a chicken and egg type of approach. If you've got very good compliance and you're doing everything that's required under Medicare, following the rules, having adequate and contemporaneous records, then it's quite natural that you won't be able to see the very, very large amounts of patients. And equally, practitioners we come across who are seeing very large numbers of patients may not be able to do all of their compliance duties. So just having good compliance will mean that you'll stay on the right side of compliance, I think.
Thanks, Justin. So that's the close of our main webinar section. For those who would like to leave us, thank you so much for attending this evening and participating. However, if you would like to stay on for our questions and answers, please feel free to do so. And we'll open that section of our discussion up now. One of the questions we've received is, and I will go to Dr. Naren, I think. The question is, a doctor feels like they're being randomly audited and found to be satisfactory. Are audits truly random? And if you've just had an audit, does that mean you won't be audited again for some time? Dr. Naren.
The audits are not random. Audits are targeted. It is like audit for people who have gone overseas. We don't randomly find people. We usually find when the data is matched, there is an overseas visit. Or when someone is an outlier in a particular item and we have reasonable concern, or sometimes we do a particular item audit, there we get a high billing % for those items because they are outliers. So generally, they are not random. We did some audits some time back as selected outliers and randomly selected people. We found out that we unnecessarily hassle people if you randomly select people for audit. So it is generally selected outliers because it yields better results. As 52% of the people who were audited have to repay something. So it is more targeted. So it is never random. And once audited doesn't mean they won't be audited again, because it depends on the issue. Because otherwise it will give you a free license to do whatever you want for the next few years or whatever. So it is never, you will never be audited again.
Thanks, Dr. Naren. Another question comes in and it says, I work in a field where most of my colleagues work in public, so I'm seeing and billing more as a full-time private worker. I can't see how I can avoid compliance review audits if I'm always going to be at the end of the bell curve due to my work hours. David, I might turn to you for that question. Are you able to respond?
Yeah, so I guess the short answer is your peers are your specialty in terms of their MBS billing. If you're in the unusual situation where 99% of your specialty does mostly public and very little MBS billing, then there is a possibility, I guess, although I think it would be unlikely in most specialties, that you might come up as higher than your peers. We always examine the data in detail and think about what's reasonable. The 80-20 rule, for example, which we talked about earlier, is way out there in terms of the amount of activities that you might do in a day to be found by default to be practicing inappropriately. So we have many practitioners, medical practitioners who work in this area who examine the data and put a common sense lens over it as to what would I expect a practitioner to be doing regardless of whether they're in public or private is most likely the question they would be asking there. So I would say there's no need to necessarily be concerned simply because your peers tend to do a lot of public work.
David,
And
sorry, Dr. Naren?
yes, I would add to what David said, because we don't look at something is outlier alone is the issue, especially from practitioner review program. We look at how much of consultation, how much of review consultation. If he is seeing so many neurosurgeons in a specialist area, whether he has had enough CT, enough investigations, and what the age of the patients. So it is not one issue that triggers something. It is a comprehensive assessment of the person's billing profile. It will give an idea, because if somebody is predominantly working in public practice and only one session, their number of consultation and CTs will be much lower than this person working full time. So we can extrapolate. These are medical advisors looking at these issues.
I think that's very important that it is a whole of practice review and not a specific issue. Thank you, Dr. Naren. David, I will go back to you because even though we said we won't be looking at particular item numbers, item 132, we've received so many questions. Could you add some comments in relation to 132, please?
Yes, absolutely. So I refreshed myself on the July 2025 changes, which were primarily to specify the items that can't be co-claimed. Now, sometimes we will suggest this in item descriptors. Sometimes we'll make it a requirement that other items can't be claimed, and we'll even ask Services Australia to put blocks in their system. So that's about co-claiming of certain telehealth items that were added in, and there were already existing items, again, from my memory, such as item 110, 116, which couldn't be co-claimed with the item, and these are the telehealth versions of it. So that's one of the changes that people may have thought there's something fundamentally big changing. No, it's more a clarification. And the other clarification that I think has happened over the last few years, and people are still catching up with it, I do understand. Item 132 was designed as an item which, if I put it in plain English, a GP says, I think if I refer a patient to this consultant physician, they can create a plan which I can carry out. And if the consultant physician agrees, they create that plan, they bill item 132, and they hand the care plan for the patient with multiple comorbidities back to the GP. It's not always been used that way. It's become commonly used as this is the item I bill when I create a care plan as a consultant physician and I carry out that care plan. That's not the intent of the item. You wouldn't be meeting the item descriptor is the answer to those various questions. So I think that probably covers a reasonable amount of distance for item 132 in the questions. I recognise there will be more. Again, Ask MBS. So I saw a question about Ask MBS earlier and the answers that are provided. Ask MBS is not a legal service. We, the department, do not provide legal advice, but we will do everything we can, including providing all the information that we can from explanatory notes, from descriptors, from past questions that we've had about these items through Ask MBS to help you understand what's the right thing to do here. If you still don't know, you may need to seek advice from your lawyer or Avant or some other party.
Thanks, David. And as we said at the beginning, any specific advice, please do seek it directly from Avant, and we can go from there. We have received a number of questions in relation to telehealth issues. Patrick, I'll go to you, I think. There are a range of questions we've received. Are you able to make some comments on the telehealth aspects?
We're still getting questions, and David or Dr. Naren may want to jump in here too. We're still getting questions in relation to the need to get consent from patients where telehealth items are being bulk billed. I know there was an exemption there for a while during COVID because the whole health system would have fallen over, to put it bluntly. But what's the case now? I think technically the rule is that yes, you do need to get something in writing to say that the patient is happy for the benefit to be assigned, i.e. for them to be bulk billed. But the practicalities of that are really still getting quite cumbersome.
David or
Yes.
Dr.
Happy to
Naren?
answer that. So the short answer, which many of you may be aware of, is there's been a whole body of work that the department has been undertaking with many peak bodies in terms of what we call assignment of benefit, bulk billing and giving someone agreement that you can be bulk billed. That work is still underway, and there's a lot of consultation that's been undertaken. We understand when you're working by telehealth and some of these new methods, it's not necessarily as easy as the old paper form that you used to get, which I personally don't remember signing for quite a bit of time myself. So that's still being worked on, but it's a response from the department and the minister indeed in terms of that issue of how do we modernise the assignment of benefit process to make sure patients can be bulk billed correctly with telehealth now in play.
Thanks.
Great. Thanks, David. I'll put a link to the current advice on the Services Australia website there too. I think in a second. The other question we have been getting in relation to telehealth is that if you're not the patient's usual doctor, from the GP's point of view, and for GPs, they still must have had the established clinical relationship with the patient, is what it's called, unless there are specific exemptions. The details are readily available in the explanatory note, and I'll put a link to that in soon too. But basically, in most circumstances, either the doctor or somebody else at the practice must have had a face-to-face consult with the patient in the last 12 months, unless the exemptions apply. And rather than trotting them all off here, I'll put the link in.
Thanks, Pat. That's great. A number of questions have been received in relation to the 80-20 rule. I might go back to Dr. Naren. Some of the questions, what's the maximum number of patient consultations we're allowed to perform in a single day? I think you touched on the issue beautifully before when you said each item is a complete service. But Dr. Naren, are you able to provide some further thoughts?
I am more than happy to do it, because 80-20 rule is one of the rules put in more than 20 years ago, where the profession agreed any practitioner who renders 80 or more attendances in 20 or more days in any 12-month period. It is not calendar year or financial year, any 12-month period is deemed to have practiced inappropriately. It is the law. But if you are doing 30 item level D consultation, can you do it in a day? It is almost impossible. So there is no maximum number or minimum number item. Whether a particular volume of service could be done in a day by a practitioner working reasonable hours we understand practitioners work some practitioners work 8 to 10 hours, some work even 12 hours, but we have seen practitioners billing for more than 24 hours in a day, but they have not breached 80-20 rule. So it is important to see what you are doing is clinically relevant, fulfill the item descriptor, then you will never go beyond 80-20. The 80-20 rule applies to general practitioners and other medical practitioners. It doesn't apply to specialists or consultant physician because usually they don't go anywhere near there. But the 30-20 rule, because I thought it is part of the thing, 30-20 rule applies to general practitioners, other medical practitioners, and consultant physicians, because they can do 30 or 40 consultations in a day. If they do all of them by telehealth, they would breach the law as well. And if you want more information on the 80-20 rule, it is in the Medicare, you go to MBS online and look under GN.15.39, it gives what are the item numbers that are counted for 80-20, because the attendance are counted, not surgical procedures are counted for that. Because sometimes people misunderstand it and say everything is counted. It is not everything is counted. Procedures are not excluded. But if you have a mental health plan and a consultation, that will count as 2 attendances. So that is also need to be remembered. Hopefully,
Absolutely.
the answer.
Absolutely. Thank you, Dr. Naren. Very helpful advice. Another question we have received relates to co-billing, and in particular, what is co-billing and is that allowed? I might go to David. Are you able to assist with that question?
Yes, absolutely. So it's very common that if you're seeing a patient, you might deliver multiple clinical services, which can be described in 2 or more different MBS items. As Naren said, we do have a complete medical services rule. So there is a presumption that an example that I've used quite a few times before, and we actually ended up changing the MBS for this, is we would see someone doing hand surgery and they would claim a different item for every single finger that they did surgery on. That was one surgery and it should have been a hand surgery item generally. So that's, I guess, a version of co-billing. That's a surgical a surgical interventional type example. You will get sometimes surgery plus a consultation. That tends to be fine. One thing I will say, going back to the earlier discussions about double dipping, is you need to be quite careful in terms of where the service originates from and who you're providing it to, and is it being funded through another avenue. It is also quite common, and this is probably the thing that we pick up the most, that we see multiple consultations being billed in a day. You can bill multiple consultations in a day if you meet all the requirements of both items. Now, I won't go through all of the notes in the MBS on this. I encourage very strongly that you look at the MBS explanatory notes in this respect. They're quite good. So you can do it if you meet all the requirements. But what we do find quite commonly, and have done a number of compliance interventions on, is it becomes habitual that anytime someone sees a patient, particularly if they have someone billing for them who doesn't understand these rules, there are always 2 consultations billed, regardless of the clinical content of the service. And that's where you're likely to come under our view, and we might get in contact with you.
Thank you, David. And just while you're here, another question relates to documentation. Does the Medicare rebate apply to the time it takes the doctor to review the notes, fetch the patient, write the notes immediately after the patient has left the room, or is it just the time from when the patient sits down to when the patient gets up to leave the room? Could you answer that question?
Yes, for consultations, or what we might call professional attendances, so that's certain items specified. Again, I won't specify all the item groups. It is time spent with patient that contributes to the service. That's regardless of whether it is a time-tiered item or a general consultation item, such as a 104 or a 110. So you can do documentation while you're with the patient. Obviously, you might be taking notes, or even there may be an AI helping you to take notes. The time spent afterwards is not covered by the Medicare rebate or beforehand.
Thanks, David. I think that's really important advice. Another question, and I'll go to Dr. Naran. Does the patient have to sign a bulk bill form, or can I send direct? We may well have answered that. Dr. Naran, are you able to just provide a quick comment?
As the law stands at the moment, you need to have, because it is like a check. If you don't sign the check is not valid. The same way, when you render a service and the patient assigns you the benefit, if he doesn't assign you the benefit, you are not entitled to it. So signing the form or pressing on the arrow, which was authorized as equivalent to signing, is at the moment important. As David indicated, there are moves in ways where practices can do certain things to satisfy the requirement. And electronic signature is also acceptable. And also some of the hot doc and others, from what I understand, you can send a text message and it will reply back and say, accepted. I am billing item 23, and it will send you back, yes, the patient ticks on it. So there are several ways of doing it. I understand it is clumsy, but it is the same thing. If you sign a bank won't give you money if you don't sign the check.
That's really, really important advice. Thank you, Dr. Naran. Another question relates to referrals, and I might go to Pat for this. In the context of private patients reviewed in a clinic in a public hospital by a staff specialist, does the referral need to be named to the specialist who is reviewing the patient for the clinic to bulk bill Medicare for that consultation? Or can the clinic bulk bill from an unnamed referral or a referral named to the head of department if the patient is reviewed by another doctor or a registrar? And it's noted that there seems to be discrepancies around this. Pat, are you able to comment?
Yeah, thanks, Tracy. We've actually had a couple of other questions in the chat along the same lines. Along the lines of what years ago, those of us that are old enough to remember, we used to call it double dipping, and it was intensely prohibited, where if patients were seen in the public hospital, that was the public hospital's responsibility and had nothing to do with Medicare from the point of view of individual item numbers. However, most people will probably be aware the practice is now allowed in certain circumstances, and the certain circumstances are actually because of the thing called the National Health Reform Agreement, which is an agreement between the states and territories and the federal government. And that allows hospitals to bill Medicare item numbers under certain specific circumstances. It's not a free-for-all where they can just bill Medicare item numbers according to the MBS, the Medicare Benefits Schedule itself. And the specific circumstance when it comes to referrals is that the referral does need to be named. It's stipulated in that agreement that the referral needs to be named to the particular hospital specialist that is going to see the patient for it to be done. There has been a bit of confusion about that because out in the private world, so to speak, a referral doesn't actually have to have the specific name for the purposes of Medicare, but definitely when it goes to a public hospital doctor, it does need to have that particular doctor name in order for the bulk billing to be allowed to occur.
Thanks, Pat. In the chat, we've received a great number of questions in relation to bulk billing, and some of them may well relate to business practices. David, are you able to make a further comment in relation to bulk billing to just summarise those issues?
Yeah, so I think it would be easy sometimes to read the requirement that if you bulk bill, you levy no extra charges, as meaning essentially you either bulk bill or you don't. It's not necessarily that black and white, if I put it that way. And again, there's information available on the Services Australia website. If you're interested, I'd encourage you Google a term called split billing. And that's a term for when you have one service that you choose to bulk bill, because bulk billing is a choice. Obviously, it is with agreement of the patient. So you might have one service that you choose to bulk bill, and another which you choose to levy a co-payment. That can be a consultation and a surgical item, or whatever the case may be. So it's not a requirement that if you bulk bill on the day, everything must be bulk billed no matter what. You can make choices for your business or as appropriate. And obviously that's hopefully with discussion with the payment and the patient and informed financial consent so that they understand what they might be charged. So hopefully that helps clarify for people.
Thanks, David. That is very helpful. I might also go back to Dr. Naren. A number of questions have been received in relation to circumstances where the consultation relates to a child and how to establish that the child is participating in the consultation, particularly if it's telehealth. Dr. Naren, are you able to provide some comments on that issue?
If it is a video consultation, it is very easy to identify. Otherwise, you need to ask the mother or someone to make sure that you are attendant, because attendance item by nature need to be the person who is being attended should be there. And also, it is a good general practice. We understand the child may not talk, or 3-year-old may be shy, but seeing the child or hearing the child makes you understand the situation. Otherwise, you don't know what is happening. We are not dealing with a material. We are dealing with a human being here. So there need to be a human interaction. So all my patients, when they come, the child may sit down, mother will tell everything, and I will examine the child, but I will say hello to the child or pat the child so that the child realize she is the person of concern. So they need to ensure that the child is there for the telephone consultation. And also, if it is a very young child, most people have an opinion on whether you need to have a telephone consultation or not.
Yes, absolutely. And some of the comments in the chat are, do you have to hear the child crying? But as you've just said, it's a human interaction, and you need to establish that the child is present and then document how you do that in the notes taken for the consultation to justify that. Absolutely. Well, we're just about out of time, and we're so very grateful for all of the expert advice provided by our panelists this evening. Dr. Naren, David, Patrick, and Justin, your insights have been wonderful and so practical and helpful, I hope, for our audience members. And we're just so grateful that you've given your time tonight to provide those insights. We will be having further webinars this year, and we would very much appreciate if you would fill out the feedback form that is sent through following the conclusion of the webinar. We'll also be sending out certificates, but we have had a very high number of attendees, so we will need a couple of days to process all of those issues. Very great pleasure to have you all here tonight, and thank you all for your time. Thank you for attending the webinar, and we very much look forward to our next webinar with you. Thank you all very much.